All right. Good evening. I'd like to welcome everyone to tonight's SMRC webinar for plantar foot pain, pathology of joint using sports ultrasound. My name is Alyssa Goldenhart, and I'm one of AMSSM's SMRC officers this year and the PM&R representative. I'm pleased to serve as the moderator for tonight's webinar. I am a PGY-free PM&R resident at Mayo Clinic, obviously interest in sports medicine. And right now, been a Florida girl my whole life, just moved up to Minnesota with my cat. So if she interrupts anytime during this webinar, I apologize, but she might hop across the screen. Anyway, tonight it's my honor to have Dr. Raul Rosario-Concepcion serving as our featured speaker. And then after his presentation, I'll work as a moderator and answer any questions that pop up in the chat afterwards. So it is my honor to introduce Dr. Raul A. Rosario-Concepcion. He is a double board certified PM&R sports medicine physician at Baptist Health in Miami Neuroscience Institute, and he's specializing in sports medicine and musculoskeletal ultrasound. He earned his medical degree at the University of Puerto Rico School of Medicine and completed a PM&R residency at the University of Puerto Rico School of Medicine and a primary care fellowship or sports medicine fellowship at Mayo Clinic in Jacksonville, Florida. Professional interests include diagnosis and management of chronic tendinopathy and advanced ultrasound-guided procedures. And in his young career, he's been invited to present at multiple PM&R and sports medicine national and international meetings. He's also served as the team physician for the University of North Florida's NCAA Division I athletic teams and the USA basketball and junior national teams. Thank you so much, Dr. Rosario, for being here tonight, and you're welcome to begin your presentation.
Thank you. I appreciate the invitation to talk in this course and webinar. The topic that I'm going to be talking today is the pathology of the plantar foot using spot ultrasound and how to evaluate this structure, which is a structure that is not very commonly evaluated, and not a lot of people understand the anatomy of the plantar foot. And I feel that it's very important to understand the anatomy in order to understand the differential diagnosis that can cause sole pain or plantar pain. So I'm going to emphasize the presentation in how can we review the anatomy, scan the plantar foot, and also discuss different treatment options for different pathology. So I don't have anything to this class. I don't have any relevant financial relationship. So the objective, like I said, we're going to review the anatomy of the plantar foot. We're going to review the diagnostic ultrasound protocol that I tend to use when I'm scanning these structures. And we're going to pick like 3 or 4 diagnoses to discuss a little bit of a treatment option very briefly. But I really wanted to focus more on the ultrasound protocol and ultrasound scan, which is something that is hard to find good reference out there to teach basically how to scan the plantar foot. So the first thing that I want to bring is the mystery of the plantar foot. And the mystery of the plantar foot is something interesting because nobody knows what's going on there. Everybody thinks it's plantar fasciitis, and when a patient comes into the clinic and the patient describes heel pain or midfoot pain, it's plantar fasciitis and nothing else. So hopefully today, this presentation, you're going to learn other things that can be going on in the sole of the foot that is not just plantar fasciitis, even though that's the most common by a lot. The reason of having pain in that area. And I tried to do like a quick search of articles describing like a review of the different things that ultrasound can be helpful in the sole of the foot. And I didn't find a lot. And I found this review recently that describes ultrasound feature of the sole of the foot pathology, a review. And it's interesting that they only talk about the plantar fasciitis, plantar fibromatosis, some epidermal cysts, and dentitial bursa. And they don't touch any of the other structures that are localized in the plantar foot. So one of the things that I want to emphasize, like I said, we have to review that anatomy in that area to make sure that we have a good differential diagnosis. So the way that I try to divide the structures of the plantar foot, I like to divide them by dividing the plantar hindfoot and midfoot anatomy. And there we're going to talk about the plantar fascia. We're going to talk about the different muscle layers and tendons in that region. And we're going to talk about the deep ligaments around the plantar foot. Then we talk about the plantar forefoot anatomy, which is another difficult structure to scan. And I separated the nerve anatomy in its own section because it's something that it will help us advance the differential diagnosis. Like I said, there's not a lot of resources out there to kind of investigate a little bit of the anatomy of that foot, especially on the ultrasound evaluation. One of the best one that I have found is the Iriarte book that was published in 2021. And I'm going to reference a lot of this book and illustrations. So if somebody wants more details about how to scan and learn a little bit more, I definitely recommend the protocol by Iriarte from Spain, which is fantastic. All right, so let's start a little bit with anatomy. And anatomy is boring, but I'm going to try to make it a little quick and easy because that's ultrasound. Ultrasound is anatomy. Understanding the anatomy allows you to be a better ultrasonographer. So let's start with the more superficial layer there in the plantar foot. When we put the ultrasound probe, the first thing that we're going to start seeing is the plantar fascia. And you can see, I don't know if you know, but the plantar fascia incorporates 3 different cords. You have the central cord, you have the medial fascia, and then we have the lateral plantar fascia. The central plantar fascia is the most commonly that get affected when we talk about plantar fasciitis. The problem usually is more in the origin here at the calcaneal tuberosity, but that central cord travels towards all the toes into the base of the first phalange in all the 5 toes and creates support for the middle arch. It's a fan shape, as you can see, and it covers basically the flexor digitorum brevis that we're going to see further ahead. The medial cord do not insert in the bone. Usually comes and origin is in the central fascia, so it inserts in the central plantar fascia, and inserts in the fascia of the adductor hallucis muscle, and it's covered this muscle in that area. So we don't have a bone insertion. The lateral one, that one just inserts in the calcaneus and travels more laterally into the insertion of the base of the fifth metatarsal. This can be a little bit inconstant and irregular in different patients, but it's important that insertion because sometimes you can have some problems and pathology in that location that sometimes we address as peronis brevis problem because that inserts. We have to think also that that cord inserts in that area, and we have had some patients with symptoms in that location. If we kind of cut and dissect and we take the fascia off, then we start getting into the muscle, and the muscle have different layers. The first layer, we're going to see 3 muscles. We're going to see the flexor digitorum brevis, which is kind of deep to the central core of the plantar fascia, and it kind of travel in a different direction. It origins is in the calcaneus also, and then inserts a little more distally into the second phalange of the 2nd to 5th toes. We have the abductor hallucis, which is this muscle medially towards the big toe. Hopefully you're seeing my arrow. Alyssa, you see my arrow? Can you not?
I do not see the arrow, no.
All right, let me see if we can you see the,
Yes.
maybe the laser now? All right,
Yep.
So now it's going to be better, perfect. I'm glad I asked. So we're going to see the abductor hallucis over here. Origin is the calcaneus and inserting the middle side of the base of the first big toe there. And then we have the adductor digiti minimi, which is in the lateral side, starting in the calcaneus and inserting the lateral side of the first phalange. This muscle becomes very important when we're talking about Baxter's neuropathy. So that's something that we're going to address further on, but that's the muscle that we're going to be discussing when we talk about Baxter nerve. If we take that layer off and we go even deeper, we start seeing muscle that you have never heard in your life, and you probably heard it one day in med school and you don't remember. So I started remembering all these muscle when we started learning about the ultrasound application. So that's one of the benefits of ultrasound is that you start reviewing anatomy and getting better and better and better. So we started hearing muscle like quadratus plantae and the lumbricals in the foot. So in this second layer, we start with the FHL and FDL tendons that they travel from higher up in the leg. They come from the medial side, posterior to the lateral malleolus, and they travel to the plantar side of the foot, and they cross each other in what we call the knot of Henry. And this is a possible pathologic site that it can serve like an intersection syndrome because the same thing that can happen in the hand can happen here. And that's something that can happen because the 2 tendons cross each other in that location. They travel distally. The flexor hallucis, of course, goes to the big toe, and the flexor digitorum goes to the other toes. Then we have the quadratus plantae, which is deeper to the FDB, and that starts in the calcaneus, but inserts in the FDL. So it helps to stabilize those tendons in that area, and it's become very important in that location. And also it's important when we're evaluating Baxter's nerve, that we're going to talk a little bit more further ahead. And then we have the small lumbricals, which are not very important. We don't see a lot of problems in there. They are like form worm-like muscles. We see them very easily on the ultrasound, but not a lot of pathology in that location compared to other things. All right, let's go to the third layers. And yes, we start seeing more muscles that we have not remembered. We have the flexor hallucis brevis. It's this muscle that comes here and from the cuboid and lateral cuneiform bone and travels towards the big toe and kind of cross over the sesamoid bone. So at this level, we have the sesamoid, and it goes over and inserts a little bit more distal in the base of the first phalange there. In the middle of that muscle is where the FHL longus travels. So right here, we're supposed to have the longus tendon. We have also the flexor digiti mini brevis, which is a small tendon here. We don't have a longus, but we have a brevis, which is interesting, and inserts here in the base of the first phalange. And then we have the adductors. We have two heads of the adductor. We have the oblique head, and then we have the transverse head. Transverse head is easier to see on the ultrasound. The oblique head is a little bit more difficult, but the transverse head is pretty easy. And basically it adducts the big toe. And then the last layer is the fourth layer. Then we start getting into the interossea. When we have the dorsal and the plantar, the dorsal are easier actually to see from the dorsal side of the foot, of course, but you can still see them from the plantar side if you're evaluating them. We have 4 dorsal, 3 plantar. And then the other important structure that we see at this level is the peroneus longus tendon. As you know, it comes from the lateral leg and travels towards the lateral malleolus. I think I said medial malleolus before, but the lateral malleolus. And it travels over here and inserts in the base of the first metatarsal. We have also some insertion of the posterior tibialis tendon, which is, it doesn't insert just in the dorsal aspect of the navicular bone. They have some insertion in the posterior aspect. And this becomes a little more complicated. It's very hard to identify this insertion under ultrasound. And then we start seeing the deep ligaments, which is the last structures that we see in the foot. We have the short plantar ligament and the long plantar ligament. The short plantar ligament connects basically the calcaneus to the cuboid. Another name is the plantar calcaneocuboid ligament. And then we have the long plantar ligament that inserts a little more distally into the metatarsals, and it helps stabilize the fibularis longus or the peroneus longus tendon to keep it in place in that location. All right, and then now moving into the more of the forefoot anatomy. And the forefoot anatomy, as you can see here, we have an example of one metatarsal bone. If we go more superficial toward the plantar aspect, we have the plantar plate, and then we start seeing the flexor tendon, the longus and brevis. And in between the two metatarsals, we start seeing the intermetatarsal bursa, which is a possible location of pathology. And we have the deep intermetatarsal ligament that separates the bursa from the neurovascular structures in this location, which is going to become very important. When we do the anatomy in long axis, according to this probe, we tend to find the bone first and then move into the wet space. And we try to identify the nerve in long axis, and we can see that the deep intermetatarsal ligament separates the bursa from the nerve, and that becomes very important when we try to do injections and procedures in that location. We're going to discuss that more further ahead. All right, and now we start talking about the nerve that goes into the plantar foot. And the biggest nerve is the tibial nerve that travels down from the medial side of the leg on the ankle and travels posterior to the medial malleolus. And the first branch that it kind of divides is the MCN, which is the medial calcaneal nerve. Sometimes one branch, but it can be more than one on occasion, and it travels towards the calcaneus and gives innervation into the skin and the calcaneus in that area, which is important that we know where it travels. Then the tibial nerve divides into the medial plantar nerve and the lateral plantar nerve, okay? Those will go deep into the sole of the foot, and we're going to see a little bit more of the anatomy when we review the scan and the ultrasound. But the first branch of the lateral plantar nerve is the Baxter's nerve. This one travels in between the abductor hallucis and the QP muscle. And in this view, it's easier to follow that the nerve travels from the AH, which is right here, to the QP. And this is a possible compression site when you have hypertrophy of those muscles and possible pathology there. So it can mimic what we call plantar fasciitis. But it can also be compressed a little more distally in between the FDB and the calcaneus, especially if you have like plantar fasciitis, plantar fasciopathy, and thickening of the plantar fascia with a bone spur. That can be a possible compression site. So understanding that anatomy is very important, okay? All right, this is just a cadaveric example from the article by Dr. Presley and their team. They published that in 2013. And you can see the tibial nerve, the MCN. In this case, there's two MCN nerve. You can see the medial plantar nerve and lateral plantar nerve here, and the first branch of the lateral plantar nerve traveling towards the abductor digiti minimi, which is the muscle that innervates mostly. And that's the one that we also need to scan when we're evaluating. So we discuss all this anatomy, and it can be very confusing and very overwhelming, especially we're not used to hearing these names. So when we're scanning the plantar foot, we need to organize ourselves of how do we scan all these structures and make it in an organized way so we don't miss anything and we have a standardized protocol. So this protocol, I saw it first from Dr. Iriarte, also from Spain, and I really, really like it because it can organize my thoughts and the way that I scan the foot. And it divides the scan in evaluating the structures in the central area of the foot into the medial area and lateral areas. And then also in a separate scan, you evaluate the metatarsophalangeal area, which usually we're evaluating for intermetatarsal bursitis, plantar plate injuries, or mortose neuroma, okay? So let's start through the scanning protocol. But before that, we have to know what is the best way to position the patient. And I always say the best way is the best that you're more comfortable. So it doesn't matter. What we recommend is what makes you more comfortable and makes sense in your head for you. For example, this book recommends to have the patient prone with the foot outside of the table, so you can have early access and you can move the foot, or you can bend the foot 90 degrees with the patient prone, and then you scan on top of the sole of the foot in that area. My personal preference, I like scanning as supine. In my mind, it makes more sense for me to start from the calcaneus and scan up than actually start from the calcaneus and scanning down. But that's how I kind of practice, and in my mind, it breaks sense, but at the end of the day, no big deal. All right, so let's start talking about central area checklist over here. And this is kind of the checklist of the central structure that we're going to scan. We have the central plantar fascia, we have the FDB, the QP, the lumbricals, the FDL, FHL, node of Henry, the adductor hallucis, and then the peroneus longus with the short and long plantar ligaments. I kind of bolded and highlighted the structures that are more important in this scan to take a look when you are doing the protocol. Okay, so let's start with the most simple thing and the most high yield thing, which is the plantar fascia. Okay, plantar fascia, as we discussed, starts in the calcaneus and travels on top of the FDV muscle. And you can see here in this diagram an illustration from the book. You can see the central core of the plantar fascia traveling right on here on top of the FDB, and this is the QP a little bit deeper. We always like to scan in long axis first, identify the central core. The central core, even though we call it central, is a little more medial in the foot. So it's going to be a little more medial in the foot. And even you have to toggle the transducer pointing towards the big toe. You have a probably better picture of the central core of the plantar fascia. When we're scanning and we're identifying pathology, you can see the different thickness from the other image. You can see the thickness of the plantar fascia, and that's something that we can measure. We can see the heterogeneous ecotexture of the fibers, hypoechoic area into the structure, and we can see even tears in occasions. So you can measure it. It has been described that less than 4 millimeters is very normal, and more than 5 is abnormal. Between 4 and 5, some authors have some discrepancies. And so that's kind of varies. I recommend to compare with the other side, but sometimes the other side also looks pretty crappy and pretty pathologic. So it's hard to say, but most patients, when they have plantar fasciopathy and plantar fasciitis, they have more than 5 or 6 and even 7 millimeters. So it's very obvious. And when we scan in short axis, when you can see here the orientation of the probe in the orange rectangle, you can see the thickening of this circle of this plantar fascia and this structure over here. Okay. Also in this scan in this area, you can also see the movement of the fat. Okay. You can evaluate for fat fractures, for example, and you can have like an injury in the fat. You can see that for different reasons, but multiple steroid injection in that location can be one of the reasons. So that's why we try to avoid a lot of steroid injection in the plantar fascia. But evaluating the fat also gives you information in that area. In order to help you distinguish the fat and the plantar fascia, sometimes you can put pressure on the side of the foot, and you can see the fat will move and the plantar fascia will not. So you can see the two layers kind of moving against each other, and it can help you identify the structures a little bit better. Okay. In this case, it's hard to see in this image, but he might have like a partial tear injury in this area with this hypoechoic region, but it's important to make sure it's not anisotropy. So clinical presentation, very common problem. You can, of course, we know that it's a gradual onset of heel pain, often it's worse in the morning when you stand out of bed or after sitting for a long time and then standing. Your patient describes significant pain. At the beginning, the pain tends to get better with activity and movement. Eventually, it gets worse and it's hard to get it better. Pain located, they describe in the plantar medial aspect of the heel. Walking, running aggravate the symptoms, and not walking and putting weight relieve the symptoms. Physical examination, of course, we want to see some tenderness around the origin of the plantar fascia, especially in the central cord. You can do some special tests like windlass test that basically is dorsiflexion of the toes. By dorsiflexing the toes, you are stretching the plantar fascia and putting more pressure that can reproduce the patient's symptoms. Most of these patients have pes planus and tightness in the Achilles tendon, so checking the biomechanics and the kinetic chain becomes extremely important. The rest of the exam is pretty normal strength, normal range of motion. And ultrasound is extremely beneficial for this. I just found this study that says that it has a sensitivity of 100% and specificity of 81%. So ultrasound can be very useful in this pathology. Treatment option, very briefly, like I said, I want to focus more on the ultrasound than the treatment and clinical presentation. Rest, conservative option, activity modification. If the patient is training and running a lot and they're having pain, we need to rest from that activity as this is being an overuse problem. We can check the footwear. We can check the shoe insoles for more support. We can check for night splint to stretch overnight or night socks. Physical therapy to check the biomechanics, strengthening of the Achilles tendon and the kinetic chain ahead, evaluating the running technique and the sport technique becomes very important. Of course, we can order some oral medication for pain, symptom relief. This will not affect the trajectory of the disease, but it can help with the symptoms until we get the patient better. Steroid injection in this area, we are being more careful with this. In the past, everybody got multiple steroid injection and that was a treatment option. Now I try to avoid it at all and try not to offer it. In patients that are a little more pushy, I tend to convince them, let's do one on the ultrasound guidance, put it in the right place. It's going to work. Most likely the pain is coming back. And at that point, they're more ready to maybe take the next step of different options. So you have to kind of deal with the patient and make a deal with them. Shockwave therapy, extracorporeal shockwave therapy has become a standard of care, in my opinion. The results have been fantastic and it's still very conservative with very low risk. So it's something that I consider first or second line. And then if things are not getting better in 6 to 8 weeks, we start talking about advanced procedures like orthobiologics, like plaque-rich plasma, or the use of tenotomy with other devices like the ultrasonic debridement and tenotomy device, or the hydrosurgery tenotomy device that are in the market right now. And the last option is surgical intervention, where basically my understanding is that they cut the plantar fascia and let it hang. So I'm not too fan of trying that option, but most of the time we can get them better with other things. Talking about the plantar fascia, another possible pathology that can happen is what we call plantar fibromatosis. Usually this problem is more close to the arch of the plantar fascia. It's not in the origin of the plantar fascia. You can see the development of these nodules into the plantar fascia. So you can see here the fiber of the plantar fascia right on top of the FDB muscle. And you can see these hypoechoic kind of circular structures that are the nodules that the patient develops here in long axis, and this view is short axis. And here we have a nice video and of the nodules of one of my patients. You can see one nodule there, and then the plantar fascia is right here on top in short axis. And you can see another nodule in this location. Okay, in this view, we have the FDB deep to it and the QP even deeper. The presentation is a little bit different than the plantar fasciitis, so it's important to distinguish. The patient usually complain of this kind of slow-growing firm nodules on the plantar fascia, usually painless initially, but eventually, once they get bigger and bigger, it start giving them some pain when they press against footwear. Usually, they don't have a history of trauma or injury or any changes in the skin or anything like that. You can just feel the palpable firm nodule. That's typically non-mobile around the arch of the foot, and patients usually describe that they're getting bigger. Ultrasound, like I said, very useful. Treatment option, conservative options, we tried them first: rest, activity modification, footwear, like we discussed, physical therapy. Steroid injection, we can try it. Not sure that it can help very much. Shockwave therapy, not a lot of evidence with this because nobody has studied it very well, but it's something, in my opinion, that can be considered and tried because it's still very conservative. In my practice, I have had some actually good result with transdermal verapamil 15%, which is very interesting. There's not a lot of science behind it from a good scientific clinical background. There's some basic science behind it that it can decrease the nodule size and decrease the pain. In all my patients that we have tried it, it has been very safe and has decreased the size of the nodule and the pain. So we tried it for a couple of months. They are happy and never see me again. So I think the results have been pretty good, and that's something new that not a lot of people understand about this option. Then we have surgical intervention to remove the nodule, which is something not very commonly done. All right, so to keep scanning the central area on the checklist, we start going deeper. And like I said, we have the plantar fascia right on top. Deep to it, we have the FDB muscle. And even deeper, we have the QP muscle. And even deeper, we start seeing the ligaments of the plantar foot, like we discussed. We have the long plantar ligament and the short plantar ligament. And you can see here in the visualization, the long plantar ligament will be on top over here, and the short one will be here in between the calcaneus and the cuboid. In this area, we can see the fibularis longus or the peroneus longus tendon. It's here in the cuboid groove, where it travels deep to the lateral plantar ligament. If we turn the transducer in the short axis plane, before it was, as you can see, in the long axis to the plantar fascia, here now we're short axis to the plantar fascia, we start evaluating these kind of structures. And you can see here in this diagram that we have the plantar fascia right on top, very thin. And then we have the two muscles, the FDB and the QP. It's very interesting because this book, and I like it, they describe this muscle as the Pac-Man sign because it looks like a Pac-Man, as you can see here. And basically the Pac-Man is eating the dots, which are the FDL tendons and the FHL. So this is actually a very good home screen to start scanning after you scan the plantar fascia, to orient yourself and make sure that you know where you are. So it's very easy to identify this Pac-Man sign in order for you to continue the scan. And you can see here, you can see very well the FDL, but the FHL has anisotropy, okay? This tendon is very hard to get both. Looking at the hyperechoic, so you have to use anisotropy if you want to scan one or the other, okay? And then deep to it, we have the peroneus longus tendon, which we're going to scan further. Like we discussed, the knot of Henry basically is before this tendon kind of enters into the Pac-Man, you can have the intersection syndrome in this area. And this is a normal scan. It's not something that I have seen very frequently, one or two times. We can see one tendon over here, and the other one is anisotropic. You can see over here. You can see some neurovascular structures and some nerves right on top, and this is the lateral plantar nerve that will travel first. The lateral plantar nerve will travel first in between the two muscles, the FDB and the QP. And then the medial plantar nerve kind of rests next to the knot of Henry. And this is a possible problem because if you have inflammation and tenosynovitis of those tendons, it can irritate actually the medial plantar nerve, and you can have some neuropathic symptoms from that, and that's why we got jogger's foot, right? So that's something that we can scan and identify in order to be more specific in the treatment plan of the patient. If we continue the scan, remember before we were scanning around this level and we started moving a little more distally. So at this level, we can see the QP is getting smaller. You see the FDL now is dividing into the 4 tendons that goes into the toes, and the FDB is still a muscle. And you can see over here, and you can see the 4 tendons in this area. If you continue to go distally at the level of the C, you can see that now the FDV is completely a tendon and it's become like a tendon. Now we're very close to the metatarsals. The FDL also is there, and you start seeing this muscle that comes after the FDB. The FDA goes away, and then you see a muscle. Those are the lumbricals, which are easy to identify. And then we can follow that distally even further to evaluate. All right, so let's talk a little bit about the distal fibularis longus or peroneus longus tendon, which is another possible pathology that we can review. In this guy, when we want to scan it, we have to turn the transducer in a transverse oblique plane. You can see that it's a little bit of oblique because we want to follow that trajectory of that ligament until it inserts in the first metatarsal. So in this scan, we can see the cuboid, the first metatarsal, and this fibular structure in long axis inserting in that bone in the cuneiform and the first metatarsal. We can see the QP a little bit obliquely and the FDB a little bit oblique also. And here you can see tendinopathic changes. You can see hypoechoic changes, heterogeneous echotexture, suggesting of tendinopathy. We see that more in dancers, right? Ballet dancer that they have to stand in their toes, sometimes in runners, which are the classic presentation. So you can have pain near the cuboid in the plantar surface in the insertion. You can have gradual do-over use of running, walking, and dancing, specifically the times that I have seen it with dancers. Weight-bearing activities can increase the pain, and rest of the activity can improve the pain. And sometimes it happens after ankle sprain or instability. If your ankle is not working properly, you can put more stress in that tendon and start having problems. You can have tenderness, so knowing your anatomy, so know where you palpate and that insertion to increase your chances of getting the right diagnosis. You can have pain with resistive eversion or plantar flexion because that's what activates the tendon. And in the gait, usually in the push-off, is when they complain. We treat this like any other tendinopathy. We have activity modification, relative rest, footwear adjustment, orthotics, physical therapy, kinetic shame evaluation, strengthening. Steroid injection can be considered also for diagnostic purposes. Try to put a little bit of steroid to make sure that that's a problem, and then you can go further down the road of treatment options if the pain comes back. Extracorporeal of the therapy can be considered. Not a lot of studies at all with this tendon, but we use it for other tendons, so it can be definitely considered. PRP can be considered. I'm expecting I've never done it in that location, but I'm expecting that it should hurt a lot. And then we have surgical intervention as the last resort. All right, so those are the structure that we scan in the central foot and the checklist. Now we go through the medial foot in that area. So we start with the medial cord of the plantar fascia. Then we go a little bit deeper to talk about the abductor hallucis, talk about the flexor hallucis brevis, flexor hallucis longus, the medial sesamoid, which is a possible area of pathology, and talk a little bit about the intersesamoid ligament. All right, this is smaller. Hopefully you can see it. We start with the probe here in short axis. Short axis, it kind of works better for identifying this structure than long axis, especially in the medial and the lateral aspect of the foot. We can orient ourselves with the Pac-Man. You can see the FDB here, the QP, okay, and we have the FDL and FHL. So you orient yourself, you start there, and then you move more medially, and then you identify the abductor hallucis, which is this big muscle over here with this tendon there. And you can continue to move distally until that muscle is becoming smaller. And a new muscle comes into view, which is the FHB, which is this big muscle. And it seems that that one is eating one of the tendons here in the middle, which is the FHL. And those travel kind of basically together right on top of there until they arrive at the level of the sesamoid. At the level of the sesamoid, the FHL tendon travels in between those sesamoid, and the brevis, sorry, this is the longus, and the brevis travels right on top of the sesamoid and inserts just distal to the sesamoid. This is a good view to see pathology also of the sesamoid. You can see fractures. You can see maybe some stress fracture if you can see it enough there. You can see degenerative changes in some of them, and you can sonopalpate that area and move it a little bit and see if that's painful. And it's something that it can be injected if it's more degenerative changes, you go deeper to the sesamoid in that location. The intersesamoid ligament is the one right here that you can see in that location deep to the FHL tendon. All right, those are the structure of the middle foot. The lateral foot, we have even less structures. We have the lateral band of plantar fascia, and we have the adductor digiti mini with the flexor digiti mini brevis, which are the most important. In this area, we scan a little bit more proximal into the foot. We find the adductor digiti minimi, which is this big muscle over here. It's small, but we can see it big here in the image with the tendon, central tendon there. If we move a little more distally, we start seeing that that muscle gets smaller and a new muscle comes into view over here, which is the FDMB. And then if you continue to go distally, you can see the insertion of both ligaments, one in this side and one on the other side in that area, and you can see for pathology. For me, this view is very important because when we're scanning for Baxter's neuropathy, when there's a chronic neuropathy and it has been there for a long time and it's very severe, I want to see if there's atrophy in this muscle. So that's something that I would like to scan when we're dealing with heel pain. All right, let's move on now to the metatarsal wet space or the forefoot. We want to evaluate the plantar plate. We want to evaluate the deep intertarsal ligament, the FDP, FDL, and then the interdigital nerve to evaluate for possible mortise neuroma, the intermetatarsal bursa for bursitis or bursopathy, and then some ligaments in that location. So let's bring that image that we reviewed before and put some ultrasound correlation next to it. We have the metatarsal bone over here when we are scanning the short axis. So we have here in the visualization of the C in this diagram, we have the plantar plate, which is right on top of the metatarsal bone. And then we have the flexor tendon right on top of the plantar plate. And in between those, the two bones, we start seeing the deep tarso-metatarsal, sorry, the deep intermetatarsal ligament. And then there are neurovascular structures in that location right here. In long axis, we can see a better view of the plantar plate. So when you're seeing for pathology on the plantar plate, I recommend the more long axis view. You can see for tears in that location, and you can see the tendon right on top. I recommend to move and try to passively move that area to see if we can separate the plantar plate and see the tear a little bit better. And the most common thing that we scan in this area is more actually for mortise neuroma. So we like to find the bone, then move into the wet space in between the two metatarsals. And we like to get this view, which is not very easy, okay? It's not that easy like in this perfect view over here. And you can see the nerve traveling as a hypoechoic structure over here, and it's very hard to see it that way. You can put pressure, and you can see here in the image, putting pressure and putting everything closer to the probe allows you to have better visualization. This area here is actually the thumb of the hand. So make sure that you see that when you're scanning and you don't confuse what you're seeing. The most important thing is to identify this intermetatarsal ligament, because that will separate the superficial versus the deep structure. And the deep structure, when you're scanning from the dorsal side, which you can scan from the plantar side also, I like to scan it from the dorsal side, The deep area is where the nerve is going to travel and the vascular structures, and the intermetatarsal bursa will be right on top. And it becomes important because when we're doing injection there, sometimes when you have mortal neuroma, most of the time you have what we call the neuroma and bursal complex and bursitis. So you can have both the intermetatarsal bursitis and the neuroma. It's hard to figure out which one is giving you the symptoms. So I like injecting both. So when I come here in between the two toes, and I like to inject and identify the nerve, I inject the nerve, but also go superficial to the ligament to make sure that I inject the bursa and increase the chances of the injection working. Okay, this injection, I think the result is not fantastic from the data and the studies, and mainly probably I think is because we inject only deep to the ligament and not both in terms of symptom relief. So that's something that we can consider. Clinical presentation for motor neuroma, we have pain between the third and fourth more commonly, but you can have it in between the second and third also, which are the second more common. Some patient can describe this burning and tingling sensation. Some patient can describe this feeling of a lump or a pebble, or when they're walking, they feel like something is in their sock in that area. It tends to get worse with activity, and high heels, putting pressure there in the forefoot, definitely can increase your symptoms. When you're doing a physical exam, scanning in between the metatarsal head can reproduce a patient's symptoms. We can call what we call the Murdoch's click, which is a purple click when you squeeze the metatarsals together. Sometimes you feel this click in that area that we call Murdoch's click, which is basically the neuroma being compressed in between the two bones. And actually, we can see them. If we scan it in short axis view, in between here, when we do the squeeze of the metatarsals, sometimes we can see this balloon-like kind of structure popping into view in that area. So that's something that we can identify also and record for diagnostic purposes. Treatment options: footwear modification, orthotics, metatarsal pads, padding, steroid injection can help with the diagnosis and treatment. Some people can offer some alcohol sclerosis injection or cryogenic neuroablation that some people perform. And then surgery is also something to consider. All right, now let's transition towards the plantar foot nerve. I think this is going to be the last section that we're going to be talking about. I wanted to make sure that we have enough time for questions. All right, so let's review again the anatomy, all right? We discussed before, we have the tibial nerve, the first branch that comes down. If we are scanning, it's going to be the MCN, which is not in view here, it's already separated. And the tibial nerve then divides into the medial plantar and lateral plantar. So in this view, we're going to see the medial plantar nerve and lateral plantar nerve. And then we continue to scan this structure in this angle. We're going to keep the probe in that same angle and just continue to go down towards the heel. If we continue to go down, well, before we continue to go down at this level, I just wanted to mention something in this diagram, that when we have the lateral plantar and medial plantar nerve, like I said, the lateral plantar nerve kind of travels in between the FDB and QP first before the tendons. So don't confuse it with the tendon, which sometimes can be confusing. And it kind of travels next to the FDB muscle. So make sure that you follow that. The medial plantar nerve travels from the knot of Henry over here, and it stays here a little more medial in this location. Okay, so I just wanted to emphasize that when you're scanning. Now, we focus on the lateral plantar nerve because here we have the view of the FCN, actually. We have the lateral plantar nerve, and that first branch, that green kind of arrows, is that first branch that is the Baxter's nerve. It's a very small nerve. This is not easy. You have to scan a bunch of time, and even when you're scanning a patient, you have to stay there for a while, try to identify everything until you kind of pops out to your eyes. And once you see it, then it's easy to follow. It's hard to lose it because you know where it is, and it's kind of easy to see. We continue to follow it until you can find it in between the abductor hallucis muscle and the QP, which I said that's where it travels. In this view, it's a kind of a nice view here in this article by Dr. Presley. But when I scan this area, we see a lot of vessels also in this location, which complicates things in terms of what are the vessels, where's the nerve. So it's kind of hard to identify, so you have to take your time and do it. If you see the nerve, it's something that you can inject in that location. If you don't see it, you can inject the plane, the the plane between the AH and the QP, and most likely you're going to block it. Make sure that you don't use a lot of volume. 1 ml is enough, because then you're going to be blocking a bunch of nerve. And if you want to do it for diagnostic purposes, then you have to make sure that you only block the Baxter's nerve. Clinical presentation, this is something that I think is not diagnosed enough. It's a very common thing that can cause heel pain. It creates this chronic burning, aching pain that basically seems like it's plantar fasciitis. It's the pain in the same location, patient complain similar pain. Sometimes they can have some neuropathic symptoms, but sometimes they don't. They can get progressively worse with activity, like plantar fasciitis. But the difference is that they don't associate too much the pain too early in the morning when they wake up, or when they're with prolonged immobilization. And also when you're doing the physical examination, when you touch the plantar fascia, if it's not tender, start thinking that this might be a possibility. Doesn't mean that it's not plantar fasciitis or plantar fasciopathy, but it's something that it should be in your differential as a possible diagnosis. Possible Tinel sign. So basically what I do, I try to palpate a little bit more medially, higher up into the heel, not so much in the bottom, a little more medially, and see if that reproduce the patient's symptom more tenderness. Patient have more tenderness there than in the bottom, where the plantar fascia is something that sparks my interest. There's a possible weakness of the adductor GT minimi muscle. I don't see that very frequently. This is more in severe cases. And the rest of the exam is pretty normal. Pretty complicated to treat. We always try conservative option, like we discussed before: footwear modification, orthotic padding, activity modification. We can try a steroid injection to see how much it lasts. Fixing the kinetic chain, the biomechanics, physical therapy, and then surgical decompression, which they decompress the nerve, and probably they decompress also the tarsal tunnel a little bit higher up into the foot. This is one of the injections that we performed. The nerve is right here. We can see we went deep and superficial to the nerve, and usually 1 ml, it might more than enough, sometimes half, because I don't want to inject too much. So, all right, in order for us to take time for questions, if there is, take home points. Like I said, knowing your anatomy is essential when you're using ultrasound. If you don't know your anatomy, you're not going to do a good job scanning. However, learning the anatomy and learning ultrasound at the same time definitely will increase your skills. It will increase your differential diagnosis. You start learning what other possible problems the patient can have. So taking a deep dive into the plantar foot, it would be something good for everybody to do. The ultrasound is definitely very helpful as a diagnostic tool on the plantar foot, and it's something that should be considered. A lot of these conditions have similar symptoms, so ultrasound can help you distinguish in terms of being more specific in the treatment. And we always try conservative option before any treatment modalities, even procedures. So this is my social media account, and try to be more active in Instagram. So hopefully we can put some cases in the future there. I welcome everybody to follow it. And I would like to welcome everybody also to Puerto Rico, especially with recent news. I encourage everybody to kind of visit our island, which is beautiful. All right, Alyssa.
Thank you so much, Dr. Rosario. That was a great presentation. I know we kind of talked about it before we started, but like there's a paucity of literature about the ultrasound of the foot. So thank you so much for sharing your wisdom with us. We really appreciate it. If you guys have any questions, please put them in the chat and then I can ask them out loud. But until then, I did have 2 questions for you. So you mentioned that the Baxter's nerve had the 2 different compression sites. Do you figure that out mostly where the compression is based off of ultrasound? Is that more just patient telling you where the pain is? What is kind of what leads you to the diagnosis there, the area?
Very hard. So in all my scan that I have done there, because we always try to see, I didn't mention this, I forgot, when we try to find compression of a nerve, of course, we want to see thickening proximal to the compression, changing the ecotexture, losing of the honeycomb appearance, all those things. This nerve is so small that you're not going to see any of that. So it becomes very challenging that actually a diagnostic tool to see pathology itself in the nerve becomes very, very difficult unless it's very obvious in that area. So I tend to use more of the diagnostic injection if the clinical presentation to try to confirm it. And in order to distinguish both problems, it's very hard. I haven't found a way to figure out the location. I don't think it matters too much clinically. The other thing that I have to mention is I always scan the abductor digiti minimi because that's where the baxillary nerve innervates mainly. So I want to see if there's atrophy in there that can help me with the diagnosis. The QP also gets some innervation from the nerve, but not completely, but it's something to investigate in that location. And the other big problem with this diagnosis that I found is patient can have both plantar fasciitis and Baxter's neuropathy. And that's the complicates even more things. So the thicker the plantar fascia and bone spurs in that location can compress the nerve and also worsen the symptoms. So what I tend to do when it's not very consistent, I don't know if it's still plantar fascia or Baxter neuropathy, maybe I do the MRI to confirm because sometimes you can see edema in the abductor digiti minimi, which are early signs that in ultrasound we cannot pick up. And then we're like, but you find plantar fasciitis on the MRI. So I use the injection as my tool. So I tend to or inject with anesthetic the plantar fascia and see if all the pain gets better. Then we know that mainly is the plantar fascia. Or I inject the nerve and see if all the pain gets better. And then that helps me decide what treatment before doing, for example, PRP or 10X. If it's confusing, I don't want to do it. And actually the Baxter nerve is giving the patient more trouble. I want to confirm that. And if it's more plantar fasciitis, then I can go ahead and do more tenotomies or orthobiologics.
And if you were going to inject the plantar fascia, I know there's some different literature describing superficial versus deep. What is your personal preference? If you had to, I know it's to go to, but.
I do superficial. I think it works well. It's simpler. It's less painful to the patient. So that's how I do it. I make sure that I try not to inject the fat, which is important. And I only do one if I'm doing steroid. If it's just anesthetic, I'm not too concerned about it. But if I'm using steroid, I only do one if the patient forced me to do it.
Okay. And then my second question, for the plantar fibromatosis, I'd never heard of the topical verapamil. Is that something patients will use just like once a day, or is it multiple times? Do they get instant pain relief with it?
So it's not instant, number one. Ordering it is a little challenging. I found this pharmacy that we can talk offline. I don't want to promote anything, but they do a compound of this and they educate the patient also about how to use it correctly. It takes like usually the first 3 months, you start seeing the decrease in size of the nodules and also decrease in pain. So it's more of a progressive kind of treatment. Don't quote me, but I don't remember if it's once a day or twice a day because it's something that I don't scan it, I don't prescribe every day, so I always have to go back into my prescription to kind of give the patient the information. But the results have been pretty good, and I learned that during my fellowship. I haven't heard a lot of people talking about it. I started using it because we don't have a lot of options, and the result has been pretty good. I tend to always it's verapamil. So if the patient have a lot of hypertension and a lot of medication, it always sparks my interest of if it's a good idea or not adding kind of verapamil that can affect all that. Well, most patients, they have control blood pressure, and I don't have too much concern about it.
Awesome. Well, thank you so much. I don't see any other questions in the chat for now. I do have 2 updates if you guys would hold on for 1 second. So before we conclude, we have 2 other events coming up soon. If you guys are free and able to join, I think they're going to be great. Next Monday, November 4th at 8:30 Eastern time, we're going to be holding our journal club meeting with the students. It's going to be the top 120 articles every sports medicine fellow should be familiar with. And then it's focusing on the topics chronic leg pain in athletes and comprehensive approach to evaluate the groin pain. And then on Thursday, November 7th at 8:30 Eastern Time, the student interest group will be holding their webinar series. And this will be the textbook injuries and presentations by Robin Knudsen, Troy Schmurma, and then Dr. Dana Kotler. And those are going to be on figure skating, triathlons, and then cycling and Pilates. And let's see, I'm going to hold the chat one more time. Still no more questions. So I just want to thank you so much, Dr. Rosario, for coming to talk to us. We really appreciated your time chatting with us and teaching us all tonight. So thank you so much.
Always a pleasure.